Welcome back to the 49th Annual AAKP National Patient Meeting. I hope you had a fantastic break and are ready for exciting sessions that we have ahead for the rest of the day. My name is Ed Hickey, and I have the privilege of serving as president of the American Association of Kidney Patients. I'm a CKD patient and have been a care partner and advocate for family members affected by kidney disease, which has given me a deep appreciation for the challenges patients and their loved ones face. At AAKP, we work to ensure that patients have a central role in the research and development process, as well as in the development of policies that have a direct impact on their care. The field of kidney disease innovation has experienced remarkable progress in recent years, bringing to us new drugs, diagnostics, and devices. As companies continue to expand the horizons of medical science, the future of kidney disease treatment looks promising, and the potential to improve outcomes for individuals with kidney disease is vast. That's why it's my honor to introduce our next session titled Under the Dome, Industry Harnessing the Power of Patients in Research, Innovation, and Advocacy. This program features two outstanding companies which understand that true patient engagement is not just to check the box, but a substantive part of R&D in shaping the policies of tomorrow. Today, we're honored to welcome three distinguished guests who will provide examples of best practices and how to effectively partner with patients and how those engagements have led to or are leading to success. First, I'd like to welcome my good friend, Tamara Windau-Melmer, Director of Advocacy Relations for Bayer Pharmaceuticals, U.S. Over the past 3 years, she has been dedicated to establishing authentic partnerships and executing meaningful initiatives together with patient advocacy groups and medical associations in the cardiovascular and renal space. Tamara and her colleague Melissa Penn, Global Director of Patient Engagement R&D, spearheaded efforts to positively transform the way Bayer defines and incorporates patient engagement into their company culture and activities. This effort led AAKP and Bayer to be recognized with a 2024 U.S. Reuters Pharma Driving Health Equity Award. Tamara joins us today to share how Bayer is leaning forward to bring together key organizations throughout the kidney community to drive efforts to ensure equitable kidney care and break down barriers in screening, diagnosis, and treatment. And as an aside, Tamara introduced me to Freeway, which is an experience that I'll never forget. And Freeway and I are now Instagram friends, and it sort of elevated me a few levels in my kids' eyes, so I thank you for that. So, Tamara, I turn it over to you.
Good afternoon, everyone. It is such an honor to be here with you all, and thank you for that very nice introduction, Ed. I really appreciate it. Thank you to the American Association of Kidney Patients, but especially all of you here today, here in Orlando and online. As Ed said, I'm Tamara Windau-Melmer. I'm the Director of Advocacy Relations at Bayer Pharmaceuticals, and I'm going to spend some time today talking about the need for federal screening recommendations for chronic kidney disease and the power of all of you through advocacy. Speaking of Freeway, there's Ed's new best friend. But let me start with a quote from someone I admire and I greatly respect. Freeway is a platinum recording artist and founder of the Freedom Thinkers Academy, which is a nonprofit committed to revitalizing the community of Philadelphia by disrupting the cycle of generational poverty and addressing the African American achievement gap. He said, "I feel like once people are aware that there is hope in available treatment options, they will be quick to get tested. When I was diagnosed with kidney failure, that was it. Dialysis was it. We have to spread awareness and let people know that they now have hope. Hope is everything." Freeway had a kidney transplant, and he's one of the busiest individuals I know. Between his concert tours and work with the Freedom Thinkers Academy, he has also dedicated himself to educating the community about risk factors for kidney disease. because despite having high blood pressure and diabetes and a long family history of kidney disease, Freeway had never been screened for kidney disease himself. And Freeway isn't alone. You all know these sobering statistics. An estimated 37 million adult Americans have CKD, but approximately 90% of people who have it aren't even aware of it. And we know that kidney disease disproportionately burdens minority populations in the United States. Black or African Americans are more than 3 times as likely, and Hispanics or Latinos are 1.3 times more likely to have kidney failure when compared to white Americans. We also know that kidney disease results in extremely high costs to taxpayers. Approximately 1 in 4 Medicare dollars is spent on kidney patients. That's nearly $157 billion a year. It shouldn't require going to the emergency room with kidney failure to get diagnosed with kidney disease, like Freeway, and perhaps some of you in the room and online. Yearly screening for kidney disease at regular checkups with your doctor could help protect kidney health and catch disease earlier when it can still be slowed and more easily managed. And there are multiple clinical guidelines that recommend annual screening for kidney disease in individuals with diabetes and hypertension, but screening is not routine. There are so many patients falling through the cracks. There are no federal government screening recommendations for CKD. So the question becomes, how do these federal government screening recommendations come to exist? So let's talk a little bit about these 2 national government entities. There is the Agency for Healthcare Research and Quality, or AHRQ, and there's the U.S. Preventative Services Task Force, or USPSTF. Try saying that 5 times fast. So AHRQ's mission is to produce evidence to make healthcare safer, higher quality, more accessible, equitable, and affordable, and to work within the U.S. Department of Health and Human Services and other partners to make sure that the evidence is understood and used. And since 1998, AHRQ has been authorized by the U.S. Congress to convene USPSTF and provide them with ongoing scientific, administrative, and dissemination support. And so then there's USPSTF, created in 1984. They're an independent, volunteer panel of national experts in prevention and evidence-based medicine. They work to improve the health of people nationwide by making evidence-based recommendations about clinical preventive services such as screenings, counseling services, and preventive medications. And to date, USPSTF has recommendations on more than 88 different topics. Examples include things like recommendations for breast, pancreatic, and colorectal cancer screenings, counseling on tobacco cessation and unhealthy alcohol use, screening for intimate partner violence and abuse. So why is this important? Why are the screenings and counseling services USPSTF recommends so critical? Well, I invite you to think about the following. Finding a lump in an annual mammogram early. Receiving resources for domestic abuse intervention services while you're alone with your doctor at a regular checkup. Obtaining a prescription for pre-exposure prophylaxis, or PrEP, which is an effective antiretroviral therapy for individuals at increased risk for HIV. Now, there are myriad opinions about how USPSTF works and operates and how their recommendations are implemented. But what a lot of this boils down to, at least in my opinion, is patient knowledge. How can you do anything to slow the progression of chronic kidney disease if you've never been screened for it and you don't even know you have it? So what you see on the screen is a flow chart that shows USPSTF's current multi-step process when developing a recommendation. And at this point in time, you can see the status of where things stand for a federal screening recommendation for chronic kidney disease, the red box with the yellow star. That's where we're at in this process. There's a final research plan, and we're now waiting for USPSTF to publicly share a draft recommendation for public feedback. Advocates like all of you have been awaiting this eagerly, because the last time USPSTF considered kidney screening guidelines was in 2012. Well, a lot has changed since 2012. There are now treatments that can slow the progression of kidney disease. And we cannot ignore the fact that CKD causes more deaths each year than breast cancer or prostate cancer. There are a lot of people out there who feel that kidney disease is the under-recognized public health crisis of today. Leading kidney patient and professional organizations recognize the need for a federal screening recommendation for CKD. Dr. Rosas, an associate professor of medicine at Harvard Medical School and the president of the National Kidney Foundation, says, "A screening recommendation from the U.S. Preventive Services Task Force is important because the majority of patients at risk are evaluated by primary care providers, not specialists. Primary care providers follow the task force recommendations, and healthcare systems frequently embed them in the electronic algorithms for care. Early identification of kidney disease could slow the progression to kidney failure and the need for dialysis." Mrs. Burton, the president and CEO of the American Kidney Fund, she shared, "I've been at AKF now for 18 years. When I first arrived, we were talking about advocating for state legislation to mandate that there be early tests for kidney disease. The primary care doctor's concern was, when I'm speaking with a patient and the patient comes back and has CKD or is at high risk for CKD, what do I tell them to do? I'm empty-handed." And that is no longer the case. And that's why it's so important for treatment options to be developed and to be well known, not only by patients, but by primary care physicians. And of course, Mr. Hickey, Ed, president of AAKP, Ed has said that over the course of the current and past 3 presidential administrations and throughout multiple Congresses, the bipartisan national consensus on kidney disease has included the commitment to drive detection and treatment further upstream to reduce the occurrence and cost of kidney disease. Any federal agency decision that falls short of this commitment to reduce the occurrence of kidney disease, including a failure to adopt early screening and detection, is fully inconsistent with national policy and should be viewed as a government determinant of health that negatively impacts people at risk and taxpayers. We know a federal screening recommendation for chronic kidney disease is needed. We know the entity who and the process of how a recommendation is developed. But while we wait, individuals who don't know that they have CKD continue to progress in the disease. So while each of us may come to the table to call for a federal screening recommendation for CKD from a unique perspective, a group did come together late last year with a singular purpose. Collectively, with Freeway and AAKP, the American Kidney Fund, the American Society of Nephrology, the National Kidney Foundation, and Bayer united to discuss the importance of screening, diagnosis, and treatment for CKD. Last December, with congressional sponsorship by the chairs of the Bipartisan Kidney Caucus, led by Representatives Bouchon and Del Bene, Bayer convened and moderated an educational briefing to elevate awareness on the need for USPSTF to discuss policy solutions that support early screening, testing, and diagnosis for kidney disease. It was an important conversation led by the premier kidney patient and professional organizations. And at the heart and center of it all was the patient voice and lived experience. Through each of our channels, Partners raised awareness and facilitated broad engagement on the Capitol Hill briefing. Here are just some examples that you can see of social media that every single partner put out. The December briefing itself acted as a catalyst. In the new year, in 2024, led by Representatives Del Bene and Bouchon, the Kidney Caucus called upon members of Congress to sign on to an official letter addressed to AHRQ and USPSTF expressing support for a federal screening recommendation for CKD. Again, partners took action, from mobilizing their networks and communities to reach out to members to stand with the Kidney Caucus, to conducting outreach and holding numerous meetings with members themselves and their staff. I recognize that many of you in the room today and online engaged through AAKP's Action Center, and that you yourself called upon your member of Congress to act. Your voice matters. And your voices further amplify those of the National Kidney Foundation's, the American Kidney Fund's, and the American Society of Nephrology's constituencies who took action. Further, they also joined those of Freeway's followers and Bayer. The president of Bayer US, Sebastian Guth, called upon Bayer employees to act. An act we did. As a result, over 900 letters were sent to members of Congress, urging them to sign the bipartisan letter. You have an incredible amount of power. When advocates like you shape the conversation and call upon your elected leaders to take action to serve the people, things can happen. And they did. This is the final letter sent to USPSTF and AHRQ on June 3rd of this year. Thanks to your and partners' collective efforts, 44 members of Congress signed onto this bipartisan letter. In doing so, 28 Democrats and 16 Republicans stated that a federal kidney disease screening recommendation would increase early detection and improve quality of life and physical functioning for millions of people, while preventing costly consequences, including deaths, kidney failure, and cardiovascular complications. Given the federal government's unique role and responsibility in the care of people with kidney diseases and kidney failure, the lack of success of current screening approaches, and the urgency of this public health crisis disproportionately burdening underserved Americans, a federal screening recommendation would improve care by enabling earlier diagnosis and intervention to prevent and delay costly kidney failure. What's next? Well, we remain tuned into USPSTF. We await the announcement of a draft screening recommendation. But we're not waiting idly. Partners continue their engagement with members of Congress and other government entities. Bayer will convene a panel session later this year with state legislators to raise this issue. And we prepare for when a screening recommendation does come to close the gap of time between when a recommendation is made and when it is implemented. And I think a lot about what Dale, you said earlier about rural areas. A policy is only as good as when it is implemented correctly and fairly across all areas of the United States. We remain engaged. We keep moving forward with urgency and hope, as Freeway does. And we stay focused on why this matters for patients, their families, and for all of us. So in closing, I want to thank you again. Thank you for your advocacy and remaining engaged through AAKP's action alerts. Thank you for your partnership, and thank you for your leadership. And with additional thanks to the partners here at AAKP, the National Kidney Foundation, the American Kidney Fund, the American Society of Nephrology, and Freeway, and the leadership and my colleagues at Bayer, I want you all to know that we will continue to press this issue until there is a system in place that better supports kidney patients. Thank you. Thank you, Ed.
Thanks, Tamara. That was wonderful. Just a little aside about Freeway. He was on tour in Berlin and found out that he wasn't feeling well, and he went to the hospital, and they said, you have kidney failure. So they immediately put him on dialysis, and he didn't want to give up his recording career. So he was on tour with Jay-Z and Beyonce, and when they were back in the United States, he would fly to an advanced city, get dialyzed, and then go on stage the next day and do the show, and then go to the next show. And he did that until he received his transplant. And sort of a model for what we hope to accomplish with kidney patients is we want to get back to work. We don't want to be a captive to the machine, and we're trying to figure out ways to make that possible and make sure that the people who are promulgating the rules understand that kidney patients want to be contributing. They don't want to be a drain. It's a part of the human psyche that you want to contribute. And when that's taken away or you feel like you're on the sidelines, your first urge is to get back into it. And that's a big focus about what it is that we do. And folks like Freeway demonstrate what's possible. And he's living a full active life today. And it's just wonderful to see. So thank you for that. That was great. I'd like to now introduce Tara Hastings, patient lead for rare diseases at Sanofi, and her colleague, Dr. Angela Hu, who is the clinical research director in rare disease group. Tara is part of Sanofi's patient-informed development team, which works to integrate patients and care partners' perspectives and priorities into all of Sanofi's research and development efforts. She works directly with patients, families, and advocacy groups to understand the living experiences and unmet needs of these rare disease communities and to solicit input that informs Sanofi's therapeutic development strategies. And immediately prior to joining Sanofi, Tara spent 7 years at the Michael J. Fox Foundation for Parkinson's Research. And Dr. Hu works within the clinical development team to help design early phase trials for rare kidney diseases, soliciting design input from patients, clinicians, and regulators. She's also a board-certified internal medicine physician. And prior to joining Sanofi, she was an attending hospitalist at Mass General. And she still works several weekend shifts a month at Mass General, where she continues to maintain her clinical footprint treating patients with a wide range of diseases. Tara and Dr. Hu will present on improving patient access through innovative trial design and patient engagement, and share how the development and design of Sanofi's new trial for FSGS has been informed by patients. Tara, I turn it over to both of you.
Thank you. Hi, everyone. Thank you so much to AAKP for allowing us to be here and talk about this today. It's been so nice to meet many of you, and just always so impressed to be with the community and see all that people are accomplishing. I am have a lot of experience with the healthcare system. I'm a cancer survivor. I have a rare disease and epilepsy, and my mom lived with Parkinson's for 12 years, so that's how I ended up at the Michael J. Fox Foundation. And definitely don't share that to garner any sympathy. If anything, the work that I do with the rare disease community really reminds me of how lucky I am, but also just so passionate about this topic and really proud to work for an organization that takes this very seriously. So I'm excited to talk with you all about it today. Okay, so I'm going to talk with you today about integrated community engagement across the drug development continuum. So again, I'm a patient engagement lead. I work on a team called Patient Informed Development, and we are embedded within research and development. So I'm going to spend time talking with you today about kind of the foundation for that, how that flows into what we're doing, and also some of what we're thinking about in terms of diversity and inclusivity in research, because we all know that's a really important topic. I do need to give a little disclaimer that the views and opinions expressed by myself and Angela today are our own and should not be attributed to our employer. So everything for us starts with our patient community charter. So this formalizes our commitments to the global patient communities that we serve. We created this with patients, care partners, advocacy partners, and we publicly share metrics that reflect each of these commitments. So we don't just want to talk about these as being important, we really want to be transparent as we strive to do this well. There's 4 pillars to it: that we develop medicines and vaccines that reflect patient priorities and unmet needs. We partner with the advocacy community, wonderful partners like AAKP, to better support them and people they represent. We improve and adapt our medicines and vaccines through real-world patient insights, really hearing from the community, and health community insights. And then we advocate for people-centered healthcare. So this flows through then to us ensuring that communities are partners through what we call integrated patient engagement. So we don't want to just be coming to the community one-off, a little bit here, a little bit there. This is really intentional milestones that are consistently built into the therapeutic development life cycle. We do that in a number of different ways: advisory boards, panels, interviews, surveys. I'm very lucky to get to connect directly with members of the community frequently, and then also those interactions with patient advocacy groups. So then the elements of integrated patient engagement in terms of research and development at Sanofi. And it's funny, so I've been at Sanofi about 2 years. When I started, about 6 months in, I got an invitation to speak at an event, and I had to go to my manager and say, I'm not quite sure how we pronounce our company's name. So sometimes you'll hear Sanofi, sometimes you'll hear Sanofi. I was told it's a global company and you can go for either one. But so everything starts with really understanding the patient and the care partner journey and their experiences. So what are the unmet needs? Where are their gaps in terms of treatment? What symptoms are most bothersome? What are those challenges that they're facing, and how does that flow into the impact on their daily lives? And then we use all of those pieces to think about study designs that can be optimized and simplified by advisors, and also that we're measuring what matters to patients. So it's wonderful to develop a therapy, but if it's not changing the things that the community really needs, it's not going to be a success in our minds. Clinical trial awareness and education. And AAKP has some really wonderful resources on their website about clinical trials. And then decision-making tools. So, of course, we would love if people participate in research, but what's really important is that community members and their families are making the right decision for them at that time point and where they are in their journey. And so we want to help to support that, whether that is that you participate or you don't participate. It's really just being able to make that informed decision. And then again, that ongoing collaboration with patient advocacy groups. So this idea that we really want to hold ourselves accountable to the communities that we're working with, we looked at how we were delivering on our promise to the communities in that patient charter that I mentioned in 2003. So really proud that 100% of our programs and our indications and clinical trials were patient-informed. We really focus on reducing barriers. I've participated in 2 clinical research trials, and it is a lot. It can be very onerous, and so we really want to think about, are there ways that we can scrutinize what we're doing to try to remove procedures or adjust things and make that a little bit more easy and reasonable for people to participate? And one of the things can be trying to reduce the amount of travel that's necessary and site visits. And so 100% of our clinical trials had a remote or a digitally enabled visit. 100% of our studies in the US have diversity goals, and I'm going to talk about that a little bit more on the next slide. And then we had 245 engagements in 2003 across 35 countries. So again, in those different ways that I had talked about, community advisory boards, panels, interviews, we really focused on connecting with members of the communities that we serve globally. So we know the complex challenges of expanding diversity and inclusivity in research require a comprehensive strategy. So we're thinking of this broadly as an organization as Sanofi. Some of what we're doing is industry partnerships. We know that we're not the only company that's very focused on this challenge, and we can do a lot more working together than we can do individually in silos. Community collaborations, for example, we're focused on how can we support in terms of diversity of the professionals who are treating these different communities, and a partnership that we have that we're really proud of is with Howard University College of Pharmacy. And then, again, I'll say it like a broken record, and this is why we're so grateful to AAKP and others, those patient relationships and working with patient advocacy groups. And also, as we're thinking about how to operationalize a trial and set up different sites where it would be run, we want to be mindful of both having a diverse team that would take care of patients in that setting, and also that it's in locations that make sense, so really having that flow all the way through. And then specifically for activities related to our clinical studies, we like to, again, that left purple box, all about collecting those insights early so that we can be making decisions based on that. We establish goals for diverse participation based on epidemiology. We are eyes wide open to the challenges with that, where sometimes this data itself is skewed and not accurate. So we try to supplement that with other sources like insurance claim data or registry data, so we can have as many data points as we can when we're setting up these goals. And I would certainly say, if it makes sense for you where you are, participation in a registry is a really wonderful and powerful thing and can inform a lot of different areas of drug development, and this is one that's been very helpful for us. I realized in my proofreading that my orange box and my pink box are pretty much the same thing, so I'll just say we conduct behavioral science analysis to kind of understand the behavior and the culture of different populations. That's going to impact how they get their care, how they make decisions with their families, and then to develop tools that can support recruitment. And then monitoring efforts using custom tools for tracking against our goals. So we have an internal system that has a dashboard. We can look up different sites and different studies, see how we're doing, and continue to adjust our strategy as the research progresses so that we're really trying to hold ourselves accountable to these goals. And so I'm going to pass it over to Angela. She's going to talk about a case study specific to trying to implement some of these in terms of what we're doing. So thank you so much.
Hi, everybody. Thanks so much, Tara. As mentioned, my name is Angela, and I'm the clinical research director for the study I'm about to speak about. In addition to this, I'm a practicing physician, so it's just hugely rewarding to be invited here today and speak within this patient community. So as Tara mentioned, I'm going to be going through sort of a little case study. Please bear with me. There will be some technical terms, but I'll absolutely do my best to define everything. So one of the sort of studies that we're designing is a phase 2 study for a rare disease called FSGS, and also its relative, MCD, or minimal change disease. And during the design process, we really made it a point to engage with the community, which is called a pressure test, to obtain feedback on certain design elements. And for this specific case, we asked 4 separate adolescents with their parents and also 2 adults with the disease very, very early on in the process, and we obtained their feedback on various elements from the frequency of visits to just the overall design to the mechanism of administration of the study drug. So this specific study is called what's called an umbrella trial design, and we titled it Result, which we think is a very fun name. This means that the umbrella trial design means that 3 drugs are tested in parallel at the same time. And so we really wanted to meet with our group of community advisors to really scrutinize the protocol together early on to understand where things might be simplified or adjusted. And we, like I mentioned before, this sort of collaboration is really something that we wanted to start early in the process because it really informs how we work with our sites and what kind of supports need to be built into the trial. So this very complicated diagram here is an overview of the study design. So just for some background, most pharmaceutical companies, as a very, very early stage, start with sort of a shell of this design. For us, this is where we started before we started engaging with our community advisors. They gave us feedback on the design features that they thought were appealing or interesting or aspects that they had questions about. I'll go through this diagram here. On the left-hand side, something called a screening process. That's very much the first phase of being involved in a clinical trial, and it's basically the process where it's determined if a participant is eligible for a study. So then in this particular study, after screening, participants will then have an equal chance of being assigned to one of the 3 drug groups. And then, if things weren't complicated enough, within each group, participants will be what's called randomized to either the active drug or placebo. Randomized just means a machine will randomly assign a participant to an arm. So in this study, the investigational drug means active drug, and then placebo is a term referring to something that looks like the active drug but contains no active ingredient. In our study, we give participants a 3 times higher chance of being randomized into the investigational drug arm versus the placebo arm. And so as you can imagine, it was very important for us to discuss with our advisors really what it meant to be on a placebo with FSGS or MCD, and some things that we could do if someone, for example, needed a different therapy during this period, regardless of what arm they're on. Another important part of study design is defining the participant population. And in our study, our 2 key features that we wanted were the participant must have had a kidney biopsy result indicating the disease of interest, primary FSGS or MCD, and he or she must have, at the time of entering the study, a severe protein levels in the urine. UPCR is just an abbreviation for that, at least 3 grams per gram at screening. And so what I wanted to highlight here is that we really discussed in depth with our advisors to understand what the experience was like with FSGS or MCD, to understand how likely somebody who met these criteria were to actually enter a clinical trial. And importantly, one aspect that really stuck out to us was participants' experience with kidney biopsies, and I'm sure that's something that many of you here maybe have some experience with. And we understood that when they had it, it was very challenging. It's a pretty involved and it's a pretty painful process. And that really helped inform us that we basically would not want to ask any participant to obtain a new biopsy just for the purpose of being in our clinical trial, just so we could decrease the burden on participants. And so the next really important aspect when designing a study is to understand what are we going to measure to actually understand whether the drug of interest is making any sort of impact on the disease progression, and how will we measure that. So on the left-hand side, you'll see the very specific measures in this particular study, and on the right-hand side, some basic medical tests that we use to measure this. And so we discussed with our advisors basically what was important to them in terms of measuring improvement. And several of our advisors did highlight that they appreciated that we are, for example, measuring the rate of partial remission. I understand that's a term that's very specific to FSGS or MCD, but the essence here is a lot of times in clinical trials, we don't count a result as sort of a win unless somebody meets a very ambitious marker of improvement. But based on our discussion with this community, it was very clear that even partial markers of improvement, let's say partial remission, were very important and clinically meaningful. We also heard from all of our advisors how burdensome it is to travel to the study sites. I'm sure everyone here can appreciate from their various doctor visits how difficult it is to cart yourself back and forth or have a family member help you do that. And that really helped us inform what tests we chose. We basically chose all tests that we could perform remotely so that we could permit almost all visits to be completed remotely. And those are basically the key aspects I wanted to highlight. And this slide is all of the photos of our entire team here at Sanofi, including myself and Tara. And just wanted to say there are a lot of people involved, not only in this study, but just invested in kidney disease research at a whole within this industry. And we're all very excited and find it extremely satisfying and are very grateful that you allow us to be a part of your journey. So thank you very much.
Thank you very much for your presentations. We'd like to open it up for questions from our live audience. Does anyone have anything they'd care to ask? I have a couple. So how do you see the... Oh, we have one? Oh, I'm sorry. The lights are blinding me.
Hello, good afternoon. Just a question here for Tamara. One of the slides you shared talked about the federal policies around testing and that it's still in public comment phase. So any thoughts you could share on how much time does this generally take to go from that phase to the next one? Thank you.
So at this point in time, the final research plan, has been finalized in that stage of that flow chart. And so we are awaiting a draft recommendation statement. And once that is released by USPSTF, they will also open it to the public for commentary, feedback, and that's where organizations like AAKP and others will review it very carefully and share their recommendations of any updates or changes. And so in terms of how long does that usually take, that's kind of the tricky part. There's no set timeline that this entity has to necessarily abide to. And so that's why I shared in my presentation that, we wait. We're waiting to hear. We don't know when we will hear this next step. And so while we wait, we're not idle. We're continuing to do what we feel we need to do. Partners are continuing to meet with various members of Congress. Partners are meeting with other government entities to continue to press this issue. Thank you.
Thanks so much for your presentations. So talking about that same subject, given that we're talking about insurance companies providing funding for these tests, what is your thought on the catch-22 that we're in, that if we're such a rare disease, I'm Jill Goodrich with the Denton Disease Foundation, such a rare disease that we don't have that care, like you were talking about freeway. If they don't think that there is a light on the horizon, what if there's not yet a light on the horizon, and yet we can't get to that point because we can't get identified, we can't get diagnosed. So it's this, lose-lose cycle. So what comments do you have about that, and what can we do as patient advocacy groups to break down that barrier?
Thanks for that question. And so am I understanding that your question is about screening recommendation for another different rare disease related to kidney health?
No, actually all kidney diseases, and specifically genetic testing so that you can understand what the disease you're dealing with. So for example, we talked about FSGS. That's one of our huge differential diagnoses. So kind of to piggyback this question is how many in the FSGS study, which of course FSGS, as we know, is just a collection of features, how many of those have been genetically diagnosed? So that's kind of the question. It's almost as if we don't get to the root of the problem. We can't cure a disease if we can't find it. And yet we can't find it if we don't get diagnosed. And yet we can't get payment for being diagnosed if the insurance companies don't think there's that light at the end of the tunnel that would qualify or quantitate the need for them to pay for the testing in the first place. If I'm sounding like I'm talking in circles, it's because I am.
You're not alone. No, thank you for that further clarification. And so, as someone who, of course, does not work with USPSTF, and so please, take what I say with a grain of salt, that as I have seen this overarching process taking place, and the fact that kidney disease, there was a lot of attention paid back in 2012, but then they put that aside because there wasn't enough evidence. The recommendations that USPSTF makes are built on very solid evidence and scientific, clinical recommendations for good reason. And so what we have been trying to share in terms of this clinical screening recommendation is that not every individual in America needs to be screened for chronic kidney disease. But we know that individuals who have diabetes, individuals that have hypertension, are much more likely to have chronic kidney disease. So let's take a look at that specific population, and let's abide by the clinical guidelines that are out there from the American Diabetes Association and others, and ensure that we're focusing on those particular patients, because there are quite a few of them, and this screening measure could catch them earlier.
Let me just follow up on that too. And just last Friday, I was in Bethesda meeting with the Kidney Interagency Coordinating Council, which are all the government entities that have anything to do with kidney disease across the spectrum. It was out at NIH, and one of the topics was exactly that. And we made our position very clear about the importance of testing, and just highlighting other areas that you have simple tests. You have a test for colon cancer now, or everyone gets screened at a certain point, or diabetes, or whatever it is. And just the burden and cost on society for kidney disease is significant, and kidney disease is the only disease where it's in statute that the government will treat kidney patients. So everyone recognizes the importance of that, I think, and the task force, I think, is getting comfortable with the data where it is now. We're certainly advocating that they should be very comfortable with it, and you're talking about just being able to prove or establish a standard that will be able to sustain scrutiny as they apply it in the clinical practice. And I think we're getting there, and at some point it will be as standard as colon cancer, breast cancer, whatever the test that would indicate kidney disease shouldn't be separate, and it just makes sense that we would have that readily available.
And if you don't mind, if I could just add, I don't want to be off topic, but I think the same challenge exists in a lot of different diseases. And if I go back to my past life, we saw that in Parkinson's as well, where it's like a cart horse. If you can't find the people, how can you move it forward? So I would love to chat offline if you would like to, because I think this is important here and in so many other venues, and is a really difficult challenge. And same thing, who's going to pay for it? In what way? When you said I'm talking in circles, I was thinking I've been spinning in those circles before, so maybe we could chat offline. It's a great question.
Hi. I want to make two comments. One is sort of a perspective comment. Years ago, one of the organizations, one of the guys in that organization was involved in the writing of the patient plan, Richard Galasik, and one of the arguments was you don't really need to test for kidney disease. It's a waste of time. Test for hypertension, test for diabetes, test for family history. That's all you need to do. But when you look at that now, you're going to miss a lot of illnesses. And there's many, many reasons why that I won't be able to go into right now. I could go into them at dinner time, but I can't go into them right now. But like, for example, I'll give a couple of examples. What if a patient's adopted? Or what if we have many patients who have normal blood pressure, no proteinuria or anything, but they end up having idiopathic kidney disease. And now that we have really great drugs and we have really phenomenal studies, I really want to applaud Ed and everybody who's saying, let's screen directly for kidney disease. I think this is an important change, which is a little bit more contemporary with what needs to be done. Secondary, I'm a real-world doctor, and when we do research, the patients are so selected. First of all, I work with one of the research groups, and they're going to come to my office with a computer, and they're going to screen all of my patients. So the patients who are already in my practice are the ones that are going to get screened. Now, the thousands of people that are seeing a doctor in the community that has no interest in research, which is the majority of nephrologists and certainly the majority of primary care doctors, are going to be missed. And the consumer-directed marketing that you all are talking about is wonderful if patients realize how important it is. But I think we need to have a bigger push to encourage patients to get into research. And the reason is because that is the only way we're going to move. We cannot move anywhere if we don't start doing research, because that's the only way we're going to get evidence-based answers, and that's the only way we're going to move anybody, even insurance companies. So I really think we do need to make some changes, and again, I applaud Ed for the initiatives that he's taking.
Thanks, Steve. If you go to our website, you can figure out how to get engaged in studies. It's a critical step that more patients need to take. We have time for one more.
Thank you very much. Yes, I had a question too to pose. I mean, if you have, focal segmental, if you have other conditions that are more rare, glomerular diseases and causes, etiologies of chronic kidney disease, they essentially have an opportunity to move forward as rare diseases. They get approved. Many of those patients, some do go on to develop final stage or kidney disease and require dialysis. But there are many patients currently on dialysis, and one of the issues is with the, there are plenty of incentives to develop grants and programs through the government, the Kidney Care Partners has programs for early stage, ASN does. The government has passed the GAIN Act and Qualified Infectious Disease Product Act and LPAD. So to get them there is fine, but the problem is once a drug is approved for a patient who's on dialysis, the bundle takes over, and the bundle does not accommodate reimbursement for innovative products to any great degree. There's a transitional program, as you probably are aware, TDAP or TIPNIs, for drugs and devices, but there is no permanent reimbursement for that. So it's one thing to develop the drugs, it's another thing to essentially have a reimbursement system that encourages innovation, because investors, either at the seed level, venture level, or in the public markets, essentially are reluctant to invest in endeavors, research, that will lead to new products if they're going to go into a socialized bundle that essentially allows only for a modest amount of innovation. So I'm wondering your comments about that, and how your companies may be able to add voices to the need for innovation for patients who are on dialysis and who are receiving transplants, et cetera.
Tony, I can just lead off by saying that we're challenging the very payment structure, and we're familiar with the road to CMS, and the director's office at CMS knows us very well. And we think that the bundle structure is counterproductive, and the development of the bundle from fee-for-service good intentions. There were some issues with fee-for-service being abused, but there has to be another model which encourages innovation and rewards the innovator for slowing the progression of the disease or developing drugs that can treat rare disease, and understand that the reason that innovation in the kidney space has been lagging compared to the other diseases, cancer, rare, whatever it is specifically related to the payment structure that's in place with the bundle. And we've made that case. We've talked to folks on the Hill about it, companies that are frustrated with the innovations and with the lack of compensation have worked with us to get their message across to lawmakers as well as to CMS. The Secretary of HHS has the ability to reach down and say, this is going to happen, and it will happen. They have all the authority in the world, but it takes a little bit of courage to do that, and it takes focus as well. So that's a challenge that everyone faces. If you have an administrator who won't, or a secretary who won't use the authority that they have, then it's sort of a fallback position. So there are a lot of tensions in that, but understand also there are new drugs that are on the horizon which will slow the progression, which can stop it in its track in some instances. And making that case is a lot easier when you have some product that you can put in front of the agency and say, look, you're going to save billions here if you put this in place, and not maintain the status quo just because that's the way it is. And then we just go around and sell courage. So that's my answer, and I'm sure they agree. So.
Yeah, I would say this is not my area of expertise, but certainly very familiar with the problem. In terms of how we think about it, this idea of the integrated patient engagement is, our hope is to have patient experience and information kind of flowing through not just the early work that we're doing for R&D, but through the regulatory process and bringing something to market. And I would say we try to be thoughtful when we're collecting insights with that view down the road of, is there anything through a patient preference study or some other manner that might be able to support that? I know it's not the silver bullet by any means, and again, this isn't my area of expertise, but I would say for people who are interested in this topic and listening, there is a lot of clinical research that is not testing a drug. It's sometimes just an observational study where you're sharing your experience, or a patient preference study. There's a lot of ways where your input can be captured if you're not the kind of person who wants to be in a trial like ours where we're testing a drug. There are still opportunities out there, and so for those who are willing to, the more we can kind of gather, the more we can hopefully move the needle. But I agree, it's a lot more than just that, and I can't really comment in more depth, but it is a really big, unfortunate challenge that I do know companies are aware of, and advocacy groups, thankfully, are trying to lead the charge for us.
Yeah, I just wanted to echo what Tara mentioned. I think you highlight a really important point as a provider. I see this every day. This is probably one of the biggest downfalls of the United States healthcare system, the payment structure. It's a huge, complicated problem that, we won't solve immediately, but just to echo what Tara said and just to piggyback off of that, I think what we really need going forward is simply more data, whether it be through observational trials or pragmatic trials, to demonstrate that therapies that actually decrease the progression of a disease, or therapies that prevent, or screening measures that prevent, will lead to cost savings down the road. And once we have convincing data of that, that can be used as leverage among advocates to actually make real change and to change policy.
All right. Well, thank you very much, all three of you. A wonderful panel. I appreciate you taking the time to be here.